All right, here we are back with part two of the post-operative knee, so let's get started. The first thing we're going to talk about is ligamentous pathologies. We're going to be looking at ACL, PCL, PLC reconstructions, MCL repair reconstructions, and multiligamentous injuries. So with the ACL, let's talk a little bit about anatomy, just another review here. The ACL is intracapsular but extrasynovial, and this is important. It says wrapped in a sheath. So it has poor propensity to heal, at least we think. There's some new studies coming out that show that sometimes the ACL can actually form a cross bridge, and I think heal itself. So in repeat MRIs, it's very interesting. This is something that needs to be explored more, but may be promising in the future for people who don't want to get an ACL reconstruction. There is some evidence emerging that maybe the ACL can heal itself, but it's probably dependent on the tear type, where the tear occurs. Is it going to be more mid-substance, or is it going to be at one of the poles? I don't know the literature that robust. I'll have to do some research myself, but it's interesting. But typically how we think of a ligament, right, is it has a poor propensity to heal. So what they've done is they've figured out that we need to reconstruct this ligament for knee stability. And the normal ACL serves as an isometric function, meaning it maintains a constant length as the knee joint moves through a normal knee motion. The ACL originates on the posterior lateral femoral condyle and inserts anteriorly on the medial tibial plateau. You can see the picture there on the right. What are the functions of the ACL? Well, the primary function is it restrains anterior translation of the tibia. And that's important. If you think about your anterior drawer test, your anterior Lockman's test, these are all going to be tests that are trying to test the integrity of the ACL. So if the ACL restrains or prevents excessive anterior translation, we want to provide anterior translation to see if this is intact or not. It makes perfect sense when we think about it that way. The ACL also acts as a secondary stabilizer to valgus stress and hyperextension of the knee, and also controls rotation of the tibia on the femur and extension between about 0 and 30 degrees. And this is responsible for that screw home mechanism. Not only is the screw home mechanism due to the shape of the condyles, but also we think the ACL plays a function in this as well. So the ACL injury grades, of course, just like any ligament, you have grades 1, 2, or 3. You can see that listed here. We're looking at percentage of the fibers of the ACL that are torn, constituting a grade, as well as what we might consider to be millimeters of translation. So there's actually a device that doctors can put on your knee to record the translation of the tibia on the femur. And the name is escaping me right now of that device. I'll try to find that. Remind me. I'll try to find the name of that for you guys. But it's a device that's used in studies to see if there's a laxity in the ACL and or grafts after they've done surgery on them. There are a lot of injuries associated with an ACL disruption, and some of these include other ligament injuries as well as meniscal and articular cartilage damage, so hyaline cartilage that caps the ends of the long bone, but also in up to 80% there are what we call bone bruises, and that's going to be the picture on the very right. So imagine your knee goes into slight flexion, and then you have a twisting mechanism where your knee kind of twists into valgus and internal rotation. Your femur is internally rotating, your tibia is externally rotating relative to the femur, and you're in a slight degree of flexion. What's going to happen is that lateral compartment of the knee is going to compress, and when that lateral compartment of the knee compresses, we get approximation of the distal femur and the proximal tibia, and thus maybe a bone bruise here. And you can see in the picture on the right how we have, see if I can get my cursor here, this shading of white within the MRI here is indicative of bone bruising. Okay, so this fluid collection here as well, anything that's more highlighted or light colored is going to be indicative of somewhere where fluid is, and so that's part of this. So again, bone bruises very common. Also, meniscal injury is anywhere from 15 to 40% when an ACL injury occurs, because this is a traumatic injury. So with this trauma, we're going to see other structures that get injured, and some of the most common are the bone bruise and the meniscus. And so not only that, though, multiligamentous injuries we'll talk about later, but if the trauma is high enough, the twist is high enough, car accident, whatever, football tackle, wrong position, the knee can twist badly, and more ligaments can be damaged, and so as well as the cartilage. So just things to consider here. So when someone tears their ACL and they're looking for a reconstruction, there's multiple choices that a patient can choose and surgeons can choose to reconstruct or remake the ACL. And so that's an important delineation. Just like we talked about in the elbow with Tommy John surgery or UCL reconstruction, you can also do a repair of ligamentous tissue, or you can reconstruct it. And so there's, we always try to repair things first, but in the ACL, there was robust literature in, I want to say it was the 90s, early 90s, of people trying to do primary repairs of the ACL, and there's a very high re-tear rate. And so what they did was they really started favoring reconstructions because the tensile strength seemed to be better, and the data of these long term was better. So now we do autografts, or what our choice is. Autograft meaning coming from our own body, and so you can see the picture on the right, all the different areas where grafts may be taken from. The most popular and the strongest, what we're finding in the literature, is still this patellar tendon graft, and the reason being is because there's two bone plugs attached to it. So you have the inferior pole of the patella, and you have the proximal pole of the tibial tubercle with the middle third of the patellar tendon there. So they use this, they make the new ACL out of this, and they go from there. You also have, becoming very popular now, is the quad tendon autograft. This has a one-sided bone plug, so the fixation's good. Here, the fixation's great in the patellar tendon because of the two bone plugs. Fixation's good here, and then the hamstring graft, the fixation sometimes not as good. We're fearful in some regards that this may stretch out over time. However, more research is needed. We think that these are a little stronger tensile strength-wise, especially for female athletes, because we know that there's a quad, and male athletes too, really, if you look at the literature, a quad to hamstring strength ratio deficit. So why would we want to take more hamstring away when we're getting good quad numbers out of these here, even though we're disrupting the extensor mechanism? Again, I'm kind of babbling on, as you can tell. This topic, ACL reconstruction, is so robust that I could sit here and talk to you for the next 7 hours about ACLs. If you go to CSM or any other conference, the people talk about ACLs all day and all night, and so it kind of gets a little boring over time. But when you guys are just being exposed to it, it's fun, it's new, and I enjoy trying to teach you guys the basics of it here. So anyways, long story short, here are your different graft types: patellar tendon, quad tendon, hamstring, and then also, and usually it's semitendinosis, by the way, and then also you have allografts or cadaver grafts, and sometimes what is used here is the Achilles tendon of a cadaver. It is sterilized, but sometimes we do know that these are weaker from a long-term tensile strength. So someone who's older, maybe 40 years old or older, that's not as active, not playing cutting sports, may choose an allograft because they won't have two surgery sites, right? The autograft, you're creating two different surgery sites, the actual reconstruction itself, and then the graft site. In an allograft, you'll just have the primary surgery site, so sometimes that's better. All right, so we just talked a lot about this. What about this middle bullet here, ligamentization of the graft? So there's no definitive data on when the graft becomes absolutely secure. We think it's somewhere around 18 months that this graft fully matures and becomes a ligament. The bad thing, though, about these surgeries is that from months 2 to 5, so we'll think about weeks 8 to 22, the patients are starting to feel a lot better post-operatively. They're starting to move around more. They're starting to feel good. They want to start jogging around 3-4 months. But this is when the graft is at its weakest point. So we have to remember this. So we have to have really good muscle dynamic strength to support the knee. So there's also been talk in the past about single versus double bundle technique. If we go back one slide to the graft choice, you can see how we may do a double bundle here, where we bundle two tendons together or fold it in half and sew it to itself to create a thick tendon that we use as a graft. So, when we think about this, there's comparable results, but really anatomic reconstruction is more important, meaning getting the graft placement correct and drilling the tunnels in the correct spot is more important than maybe single versus double bundle. So are we doing a good enough job? Well, athletes with prior ACL injury are at an increased risk of future ACL injury. There is a 6 to 25% re-injury rate. 15% who return to sport within 7 months suffer a re-tear. That's very high. And so, 1 out of 5 basically. Risk increases in younger athletes that are less than 20 years old. Re-injury is up to 6 times greater than someone who wasn't injured, and then contralateral injury is 3 times greater, so they may be favoring and injure their other side. Cutting and pivoting sports, 4 times greater. Contralateral injuries, 5 times greater in those sports. If there's a family history, you have a 2 times greater increased risk. This may be due to anatomical similarities and biomechanical faults based on physiology and genetics. What does a rehab continuum look like? It looks something like this. This is not perfect, but it looks something like this. To give you an idea and kind of think through the progression here, it's broken down into pretty much 6 to 8 week phases. So we have our red light to green light system as we've done in the past. Week 0 to 6 is graft protection and knee mobility. Again, getting extension back is the primary goal. Week 7 to 12, we're going to start working on motor control, some muscle endurance type work, hip, calf, continue with quad. Really, when we hit week 12 to 13, we think that graft's matured enough that we're going to start working on strength training. So we're strength training, and we're really starting to push the weights, this hypertrophy phase. After 20 weeks would be about 5 months out. This is when we can start doing a little more multi-planar movements, maybe some light agility drills. So you can see it says week 20 plus. Some people might not be ready to start this stuff at 20 weeks. They may need to wait till 26 weeks or half a year. They might need to wait till 7, 8 months, right? They might be very weak. So what we're really thinking here is that phase 3 can last a really long time, and they have to really prove to you when they can start progressing. So somewhere in this phase 3 to phase 4, we're going to start jogging, we're going to start running, we're going to eventually start cutting. They have to have blocked practice and randomized practice. And then really the literature is suggesting now that we do not return to sport before 9 months. There's a very high re-injury rate prior to 9 months, and even a year is even better to wait. We need that time for proprioceptive maturity. We need that time for graft maturity, more time for muscle and strength building. And there are even some PTs that suggest that people shouldn't even return to cutting sports until 2 years afterwards to really give themselves the best shot at not re-injuring. Now, the problem with that is obviously that people don't want to wait 2 years to get back to their sport. So there is that. So ACL's done. Whew, man, that's a lot. The next couple are going to be a little simpler in terms of what we go over, but the first one is a PCL, posterior cruciate ligament. So again, thinking of this anatomy first, it's intra-articular, extrasynovial. The anterolateral and posterior medial bundle is based on ligament function, inflection, and extension. And the meniscofemoral ligaments originate from the posterior horn of the lateral meniscus and insert on the medial femoral condyle and posteriorly to the PCL. The PCL and the meniscofemoral ligaments combine to make up the PCL complex, as you can see in the picture on the right. And the meniscofemoral ligaments are secondary stabilizers of the knee against posterior tibial translation. So these two work in conjunction with each other. And you can see the PCL is listed here. And here are some of those meniscofemoral ligaments, like the ligament of Humphrey. And, we'll talk about other stuff with the PLC injuries too, but these make up the posterior stabilizers. So again, just like the ACL, the PCL does the reverse. It limits posterior translation of the tibia. The posterior drawer test is the main test we use here. Also the SAG sign. So it's performed with the knee flexed 90 degrees. With any suspicion of PCL injury, the entirety of the knee should be examined because we may be concerned too about posterolateral corner injury. How do they reconstruct this? Well, similar to the ACL and the fact that they use grafts and bone tunnels. The picture on the left is the more common type, is a transtibial technique. The picture on the right, I think, is fallen out of favor here, but that's an open tibial inlay technique. You can see kind of the differences between the two. So we want this fixation within the bone is going to be a stronger construct here. So just to let you know, I didn't add any surgical protocols with this because it's going to be heavily dependent on your surgeon, one, and then two, these are not as common. So if you're seeing PCL reconstructions, you're going to want to get in touch with a surgeon and have their specific protocol. Same thing with posterolateral corner injuries. There's only a handful of surgeons in the entire country that deal with these type of injuries. These are your multiligamentous, posterior, lateral corner, vascular even at some points in times, nervous system, fibularis nerve, or I should say your peroneal nerve injuries. These are bad. These are like a hyperextension varus moment injury. So long story short, they require several different grafts to reconstruct the posterolateral corner, and the three main structures responsible for the lateral stability are going to be the popliteus tendon, popliteofibular ligament, and the fibular collateral ligament, as well as the PCL is going to be back there too. That makes up the posterolateral corner, as well as the posterior aspect, and a lot of times all of these are injured. And so you can see from an anatomical standpoint where these structures are and how they, with an hyperextension varus moment of the knee, how they may get injured. When they're reconstructed, they look something like this. So again, you can see the bone tunnels with the grafts that are inserted into those bone tunnels. Here's basically what a coronal view looks like and a sagittal view. So this takes a lot of complex planning, and also is a very intense rehabilitation. A lot of bone damage here, so you have to go slow with these individuals. A lot of times they have ACL injuries too, so just think the surgeon has to plan all these bone tunnels so they don't intersect and fracture the bone. So it's a very complex procedure. Here are some, there is a little bit of a rehab timeline. I forgot to put that in here. Here's some general things. You can look at this and scroll through. Again, not as common as ACL. As a new grad therapist, you probably will not be responsible for these types of patients. So rely on your therapists that are in your clinic that have years of experience dealing with these sorts of things to help you plan for these patients. What about an MCL repair reconstruction? Well, surgical treatment for an MCL is reserved for patients who have persistent valgus laxity or rotary instability, and usually these heal really well on their own because they're extra articular. They have a little better blood flow. So what we usually see here is that we have non-operative rehab on these cases. So the MCL, you can see one of the things, the MCL gets stressed in degrees of flexion. So if this was reconstructed, obviously what we're going to want to do is gradually increase the degrees of knee flexion over time and not force that knee to bend. So again, focusing on extension with MCL repairs or reconstruction. So is surgery needed? No, there's good research on non-operative treatment for isolated MCL injuries. Patients with superficial MCL injuries, treatment in a brace with protected range of motion and rehab allows most grade 1 and 2 lesions to heal somewhere between 2 and 6 weeks. Treatment of grade 3 lesions, however, they may recommend operative treatment, but non-operative treatment also has a high success rate here. Then finally, what about knee multiligamentous injuries? Well, this is a quote from Jack Skenzel. He's a doctor up here in the Twin Cities. He's involved in an article here from JOSPT. And he says, knee dislocations are rare injuries. However, when they occur, they represent a challenging and complex clinical problem. A thorough knowledge of anatomy and an appreciation of the risk of serious vascular and neurologic injury is required. Not only, and to unquote for a second, not only is it required during surgery, it's also one of our primary things we're looking at when the injury occurs. This can be limb-threatening, and although most patients are surgical candidates, the decision to proceed with operative management is patient-dependent. Multiple factors must be considered. The goals of rehab are to protect the repair and facilitate functional knee motion and strength. So these are super complex. You need a team of rehab individuals and doctors to work with these patients. This is a very high-stress type of injury. Lots of things in the popliteal area we don't want injured. This is going to be everything's injured. Meniscus, cartilage, everything. So there's two examples of this in the past 20-something years. One is this guy from South Carolina. Gosh, the name is escaping me, but this is his right knee bending backwards. Here's his left knee. Right, this is his right knee bending backwards. And then here is Willis McGahee, national championship game. His knee's bending backwards as well. And so these are multiligamentous knee injuries. Yikes. As we move away from ligaments, we'll move into patellofemoral pathologies, and I think of these as quad tendon, patellar tendon, and MPFL injuries. So a quadriceps and patellar tendon repair looks something like this. Basically, the quadricep tears away in the mid-substance here or away from the patella, and we have to go in, just like, remember that Achilles tendon repair, you go in with some of these Krakow suture techniques and you repair it back down to the knee. So as we'd imagine, this is contractile tissue, so we want to limit excessive or heavy weightlifting with the quadricep for quite some time. And these tend to be brace locked in extension 0 to 6 weeks progressing to opening from week 6 to 8. And again, if you're stretching this into the quad stretch, for instance, you're going to be putting a lot of strain through the repair. So we keep that brace locked in extension for 6 weeks. And from range of motion standpoint, you can gradually bend the knee, but we just don't want to add too much too soon. So from week 0 to 2, it's 30 degrees. Basically, every 2 weeks, you're increasing the tolerance 30 degrees if the patient's able to do it. You're going from partial weight bearing all the way up to full weight bearing by 6 weeks. Again, this sometimes is surgeon dependent. What about and by the way, this is for patellar tendon repair as well, so we kind of add those two in together. Medial patellofemoral ligament, or the MPFL. This is going to be a reconstruction of the ligament that stabilizes the knee within the trochlear groove. Again, as we mentioned before, over 95% from my memory of patellar dislocations are going to be lateral in nature, meaning the medial sided structures are what gets damaged. If those medial sided structures, primarily the MPFL, is damaged, the kneecap will shift laterally, and so you'll need to restabilize this from an inert tissue structure standpoint is going to be the MPFL reconstruction. It's used to correct serious and reoccurring dislocations of the kneecap, is the major ligament that stabilizes the patella, and surgeon reconstructs the MPFL to keep the patella in the trochlear groove, preventing dislocation. Repair has a high failure rate compared to reconstruction. So if they just went in and got the native tissue, repaired it, 95% success rate with reconstruction. So that is what we go towards. When we look at a rehab protocol here, it looks something like this. Brace is locked in extension for 6 weeks, but you are allowed to weight bear, open to 60 degrees for non-weight bearing at week 5, and then wean out of the brace from 6 to 9 weeks. Again, just like the quad tendon, because it's part of the extensor mechanism, we're going to limit knee bending for too long, okay, or too quickly, I should say. So there's a gradual progression of not only weight bearing, but also knee flexion range of motion. So by week 10, we hope to have full knee range of motion restored. Thank you guys for joining me on looking at ligaments and patellofemoral injuries.